I'm back.
All right.
Well, all
Sorry.
right.
Well, congratulations, everyone, for making it back.
Yep,
Eric's back on.
Jim's back.
I'm back. So,
Excellent. Well, Jim, I'm going to switch the presenting control over to you just in case that happens to me, because you're about to show your screen.
Yep.
And I'll update that site with
Okay.
the information we had.
Should be able to see my screen, I believe.
I can see it, yeah.
Okay.
perfect.
And so number 5 is the race and ethnicity codes. Now, why is this here? Because it's part of demographics or something?
I'm sorry?
Yeah, I think,
Yeah.
is this because this, you interpreting this as being part of demographics?
Yes.
Because, correct me if I'm wrong, but the only thing I've ever seen for demographics is sex and age.
Okay. Do we need to use that?
Well,
So we have sex and age already in our system.
yeah.
So is that an incorrect gap? It's not a valid gap?
Well, right. As part of a CCDA, you would get some extra information, but you don't, since you're not going to create one to send back out, you're just
Right.
absorbing or parsing the stuff that you really need. Date of birth,
Yeah, that's right. So we don't need to generate alerts off race and ethnicity codes. It's really, as far as demographics, it is sex and age.
Okay, and we already have the ability to have someone with a gender and an age in the system, so we don't need to import that.
And so you already have it in there. Okay. Okay.
So that from the CCDA part, you other than confirming it, if there's a birth date, someone says they're 1992 and you think they're 93, or
Yep.
Okay, and then we do have a question. It's driven off of gender. We only ask if you're pregnant if you're the appropriate gender. So that's it.
If maybe some guy thinks he is, then you got another condition.
Well, that unfortunately is one of the things that we've heard. I mean, just it's simplified for male and female, but we've already started to, and that happens, I guess, in a lot of the behavioral health realm with different genders. What should you do? So
and you got your new transgender group.
Yes, and you would think that there's only one, but there's several different types.
Yep.
Right. Yep.
But right now, at this point, we only have male and female.
And that's
fine.
fine.
Likely to extend.
Mm-hmm. That's okay for now. So B, therapeutic guidance based on EHR information. Patient medications aren't currently used to produce the therapeutic guidance. And so, let's see, what issues here.
All right. Is any part of this put them on meds? Is that any kind of outcome of your program?
It's not currently recommending, it recommends what type of treatment you should receive, what type of program you should be enrolled in, but it does not, at this point, recommend take a certain medication.
Well, or could it be that if you are level of care recommendations, what about, though, if somebody's on a particular medication, then suggest doing a certain lab test? Would that meet this? If somebody's on something for their liver, do a liver function test, or suggest it. I mean, that's pretty common. Somebody's on a blood thinner, then let's do a pro time. If somebody's on certain medications, let's check liver functions. So could you do it that way? I'm not talking about recommending the medication. I'm talking about if they're on a medication, than recommending a blood test or something like that.
That is something, Dr. Gassman said he could come up with something for that.
Yeah. Well, and, I don't even know if they give lithium anymore. Do they give lithium for anything?
Yeah, yeah.
Well, and so don't they do the lithium levels in some regular, so if you're seeing somebody and their own, and the CCDA comes in, and the medication there is lithium or something like lithium, the thing could be that, there have lithium levels been checked in the last 6 months, if that's a reliable bibliographic citation.
Right. Or is there a format in here that says if their behavior is something but they deny that they're on these substances, that then you trigger, I want to do a drug screen? Yeah.
Well, Dr. Gassman said there is logic that he could use, that he could apply to this.
Okay.
So based on the medication list, he could come up with some recommendations for us.
Perfect. Well, maybe I'm missing something, Wayne, and jump on me if I am. Maybe I've talked about quick decision support too much today. I thought about it. But, I mean, can't this simply be if somebody is on a particular medication, then do something?
Yeah, but I don't know if they're, I guess, are they, that's not part of the, I don't see this as part of that element in their product.
Right. Well, I just thought since it would be in the CCDA when it came in.
Right.
And they incorporate it. Because they got to incorporate it.
We need to show that we do something if certain medications on the list versus if it's not. That report has to show something different if you're on a drug versus not on a drug?
Yeah, there's 6 elements that you got to do, right?
And medications is one of them.
Right.
So if a patient is on a particular medication, I mean, there's a lot of ways to skin this cat, but I'm thinking the simplest one, which is that there's something to do with medications that triggers an alert. The easiest way I know to do it is if they're on a certain medication, because that CCDA comes in, it's got medications. So if you parse that out to go someplace, and then just to be able to see if that is there, and if it says lithium or warfarin or something, an alert is generated.
Yeah, if they're on Paxil, and again, trying to bring it into your world, then you do something else. Or if they're on Xanax or something, Adderall.
There's a lot of blood tests for make sure you're in the therapeutic range. So you would know better than us what those medications would be.
But bottom line is that alert needs to show something different based on different types of medications.
Well, we only have to show this based on one medication. We don't have to show it on all medications. We just have to have the functionality to show that we could generate an alert based on one scenario that we come up with.
Okay.
And then you pass certification.
Right. And then you're not going to be actually using that again in production because you're only bringing that in through that CCDA.
Okay.
Should we talk about that some more, or do you think we kind of got it?
The way that would look like, the way that would look. So I think I kind of have a handle on that one. It's basically if a certain medication or whatever scenario we come up with is present in the CCDA, we want something in that report to show up that wouldn't otherwise show up.
That's correct.
Okay.
With a bibliographic reference to what that trigger is. If it is, order this lab, then it's citing, somebody who says that's good medical practice, whatever that might be.
Okay. And if we have if there's some reference and it's, so all these have to have a citing. Got it.
Correct.
Yep, that sounds I've got parity with that.
Okay. And so our next one, medication allergies, are those in your system, or are those going to kind of come in through the CCDA?
Those would have to come in from the CCDA. I do not think that that's currently a question. Let me see if that's a question that's asked.
All right. And so these come in the CCDA, and they're codified with RX norm. You know, it could be like if a patient is allergic to cephalosporins, then do something, or make sure you don't prescribe Cipro to them or something like that. You know, we come up with something, but it'd be a lot like that, the medication thing, coming into that CCDA and parsed out, and then the rules. You know, that's run against the rule, and if it triggers an alert. So, but to me, it sounds like the same functionality for both of those. Would you agree on that, Wayne?
Yeah, I'm wondering if they would give alcohol a classification of being a med, or not a med, but a drug.
Well, actually, you know, there is a question that's been asked, saying, there is a question saying, has a doctor ever prescribed that you take alcohol for therapeutic reasons?
Wow.
That is one of the questions.
I wonder if there's a allergy. There may be an allergy to alcohol. May be a medication. I don't know.
Yeah, boy, I'd like to know what indication says take a drink.
Well, I'm thinking that must be a dated question, because my dad told me that doctors used to prescribe, you know, advise people to smoke cigarettes and drink. It sounded like doctors are pretty cool back in the 70s.
Yeah.
I remember that. I remember, like, so most pharmacies would have, you know, some bottles of liquor in there. Those people who came in who were alcoholics, you got to give them a drink. Come on.
Yeah.
I keep on waiting for my doctor to recommend it, but I haven't found the right one.
Well, I know they had IV alcohol was one of the things for premature delivery to, you know, to slow it down, and you go up to the OB ward and watch all these drunk ladies because they had it going IV.
What's our RX norm for medicinal marijuana?
Yeah, there is one. Yeah,
there is. Yeah. Okay, so that is medication allergies. Now, demographics, again, that is
age and gender. Usually.
Yeah, exactly.
So this is a false gap. This is not really a gap. Well, we don't have anything special off of age, but gender, there's certain things that could only happen to a guy versus a girl.
Right, but there's also, it wouldn't be really totally appropriate for you, but you can show it, is that some medication should only be given to people over a certain age. So if there was somebody, so we could trigger something off that, some age kind of thing. And actually there are a number of patients that, like about 50 meds that are on a list that should not be given to elderly people. Something like that. So we might work out. Yeah. That's 3. Lab test results. See, we're talking about doing this, with that lab file.
Yeah, so it's kind of a redundant thing. One was, we don't bring it in from an interoperable part, and then even if we did, we don't do anything in it. So I listed it as 2 gaps. Yeah,
and we don't have to do anything with it except run, the rules against it.
Yep.
We want to be able to do that. Okay.
Okay.
Ready to go on to C?
Yep.
Meaningful use security analysis, and so this is whether you want to do end-user security controls. Explain what this is.
So I saw that there's, I guess it's under linked referential support. It said the user needs to be able to modify the ASAM criteria so that the clinical decision support behaves differently.
Yeah. Well, and that is is not, it behaves differently, which means somebody got to go in at an administrative level and turn on, turn off, adjust levels, stuff like that. Would you agree, Wayne?
Yeah, role-based, like if the administrator is just taking
role-based
questions, and that's it, and then when the physician does it, that's when all these triggers pop up.
Yep. So it could be, so we need to have the ability to have, role-based. So if you have the give me alerts role, you get alerts, and then if you don't, you don't. And then, or is there something more where it says you have to, modify this saying, hey, no alerts for women, or no alerts for men, or something like that?
No, you don't have to go that far. No.
It's just configurable. You show them how you can configure it, and then turn on, turn off is configuring.
Okay.
Yep. So you may already have that.
Okay.
And some people can do it, but not everybody. It's all based. Yep. Yep.
All right. Excellent.
Okay. Yep. Citing sources for CDS guidance. And so this is this all? Yeah, this is the bibliographic citation.
So,
yeah, I think we kind of, just discussed. I mean, is this about whether you need links or you just paste the text there, or actually have these citations?
You provided, that was just, we need to have links. It's what you described to us earlier on.
Yeah. One thing in your, first of all, since we've run through these just over the last hour, does this cause your hair to get whiter or less white? Do you think it's more doable now that we've discussed some of these things? I know there's some development needs to be done, but
yeah,
does it look like we've kind of come up with? And we're kind of focused on doing CCDA as the way to go.
Yeah, so I'm looking at Yumay's hair color. He's a hard one to play poker against, but I haven't seen it change one way or the other. And Eric's in another room. Oh, he's not even on the call anymore.
Okay.
So,
all right.
Yumay.
Maybe that's an indication.
I'm still on the call.
Oh, really? Oh, okay. Sorry about that. I just saw I didn't see on the list.
And so, the thing is that with InfoGuard, that it's good to kind of have a discussion with them sooner rather than later. Have you been in touch with them recently?
We did. I spoke with Scott and someone else. I can't remember his name.
Yeah, and so just to kind of learn the fact that to do this, we're going to mimic an EHR, and we're just going to be processing CCDs and lab files. Because we're doing a little bit non-standard, but that still meets the requirements. Just so there's no surprises on test day from their standpoint, that they know what the plan is, and I think it's a very viable plan.
Okay.
Yeah.
Excellent. Well, I have reached out to them, and because I shared with them kind of what my thinking was. I did it verbally with them.
Yes.
But and also, by the way, Jim, if you refresh that page, you'll see my notes. I've been trying to update the notes that we've had today.
Let's see. Is this it? Okay, good.
So,
have you been, okay. I don't know, have you updated this? This may be...
I've been trying to do this. I've been trying to update it during our call.
Okay, great. Okay, good. No, that's good. And so that's one thing that I would want to know. Sooner rather than later is, do they understand the process? Your strategy, your certification strategy, which to me is pretty clear. And once that they say, oh yeah, that sounds fine, then I don't see any problems with it. But we want to get them to say, yeah, that sounds good. Can't wait to see it happen like that with CCDA. So we'll be mimicking some things, which is good. Now any more questions about this, or shall we do the song and dance on all things 2014? What do you think?
Well, I think we definitely have covered the gap portion. Unless, well, I guess you may and Eric, do you have any questions on what we've heard so far, where you know, you would need more in order to estimate? Because what the next step's going to be here after we have our validated list of gaps, we're going to, you know, then be engaging you and Eric, saying, okay, well, how much effort is this? How
Right.
are there any clouds here that we need to provide more fidelity on the gaps?
We have the estimate of the, or with Eric before, so I think we're okay now.
Okay. So,
Right.
I mean,
but yeah, I expect some questions are going to come up, and you can just shoot us, simple emails about those, or, cross-mapping, that kind of stuff, where we can always, arrange some more go-to-meetings, do next week, stuff like that.
okay.
So that by next Friday, it's very clear. So you can do your planning on top of everything. But we can, between Wayne and I, we've got access to all the resources that you need. So just don't hesitate to send an email or something like that.
Okay.
But definitely, as soon as you can, reach out to InfoGuard and just send them an email saying, we're going to do this, and here's how we're going to do it. We're going to incorporate some CCDAs and some sample lab files, and that's how we're going to do it. And I don't see any problem with that whatsoever.
All right.
Now, let me ask you one thing. When you get you're in your system and a rule gets triggered and you get an alert, how did that alert display, or what was the notification? Was there a
currently what's displaying is a green button that says submit shows up, meaning, hey, you now have enough information to get a clinical decision support.
And so, does that mean that there is a clinical decision support out there to be looked at?
Yeah. That means that there is a recommendation ready for you once you hit that button. I mean,
okay.
Theoretically, what happens is you hit that button, and then it produces the PowerPoint, and then you can download and see it. So right now, once you get the notification, currently is a green button shows up saying submit.
Yeah. To me that's fine, because you're getting notification that there is a alert to go look at.
Yeah, and we just need to have it so there could be an assessment that's mostly completed for a test patient, and then we incorporate the lab results that fills out this one remaining piece of information, and that makes that button show up. I have to excuse myself for one quick minute. This is being recorded, so from notes parts we're fine, but I'm getting pulled out for to check with somebody. But if you want to continue going through, I think we've covered the gaps. You may and Eric don't have any questions on that, so I think that's good. We've got that spelled out, and so really the only other portion we have now is the kind of, if we had the ability to talk about the different criteria, as well as access any sample files that might be helpful.
Sure.
So I'll be back in just like probably about 5 minutes, but you may hear.
Okay.
Should
we wait
over that?
Okay.
And so please continue without me.
Okay, sure. And maybe you heard Wayne. What sample files was he talking about? The CCDAs?
Yeah. I got that notes. I'll send them our typical GitHub and the blue button thing.
Sure. Okay, good. Okay, so we're gonna it's record. That's good. We're just gonna run through what is required for 2014. Somebody's partying. And so high level, very quick, because we're going to do this in about 30 minutes or so. This kind of just shows what the other people are getting certified on, and the difference between 2011 and 2014. The computerized provider order entry, we just really have to show that you can enter orders, applications, laboratories, radiology orders. Really hasn't changed in 2011. Orders don't have to go any place. It can essentially be common fields. So nothing really there at all. Drug-to-drug and drug-to-allergy interaction checks. These are usually done with an e-prescribing partner that does it for you, or maybe on your own databases, something like that. Y'all aren't doing that. Demographics. It says like this information has to use for CCDA. This has not changed. Let's see. Let me see if I can mute somebody. Let's see. I think Tony needs to be muted. There's a lot of background noise. Hey, that's better. Okay. Maybe just you and me now, Wayne.
Yeah, I'm here.
Okay. Okay. Are you other guys there, but you just muted? So type yes in the chat window. So I know I'm not talking
I'm still here.
Okay, good. Okay, good. Good.
Yeah, I'm here too.
Okay, okay, good. Yep. There was just a lot of background noise. But you're not doing demographics, but you know, they haven't changed it too much. They just added some modification to the sex field, and we have to add a couple more fields if a patient declines to give us information. That's not a big deal change from 2011. We're really going to talk about what the big changes are. Vital signs, height and weight, blood pressure, body mass index, growth charts. It's actually easier this year. You don't have to do growth charts. Problem list, which we talked about some, is a significant change because before we had the ICD-9 and something else. And now, as we talked in tonight, we're going to have the SNOMED codes. Everybody's having to shift their problem list over to SNOMED and then whatever else they want to do. Medication list hasn't changed at all. Medication allergy list is unchanged. I don't know what that noise is.
Yeah, I don't know. It's kind of a grinding of something.
Yeah, I don't know what that noise is coming from.
I think it's Tony. Tony still looks live.
Oh, I'm still here. Oh, is maybe my my computer's blowing into the...
Oh yeah, wow, might be.
Let me.
Okay,
I'll mute myself. See if anything's different.
Okay. So medication allergy hasn't changed for 2014. Still don't have to do food or environmental allergens, even though that's important. Critical decision support. We talked about that for an hour. That's a big change. We went through every bit of that. Electronic notes. This is new this year, but it's not a very big deal at all. The only requirement here is that you can record a note, whether you do it with, well, it comes back about every 20 seconds. So, you can record a note or, you know, by typing it or pull down menus or talk to a drag or something. And then you could search a particular note for one word or a phrase. So that's new for 2014. That's a very low threshold. Drug formulary checks, that's the same as 2011. Smoking status, y'all may have something very close to this already in your system, but it's not like it doesn't make much sense to get this certified. The requirement here is just that we are able to record or pull down menu in some way a smoking status and have associated SNOMED code with it, even if it's mapped behind the scenes through a table of that SNOMED code. So very, very low threshold. Image results. This is new for 2014. Really doesn't have anything to do with what y'all do, but the requirement here is you have to be able to show in somebody's record if there's access to a radiographic image with an interpretation that you can access. Very low threshold how that's accomplished, but again, that's part of a full EHR. Family health history. Now, I bet y'all do a family health history. This is actually pretty easy to get this one certified. For 2014, the requirement is that for the first degree, I wonder where that's coming from. Hard talk over that. Let's see. I bet, that's not, it looks like.
Okay, I'm going to mute myself.
Okay, that's probably it. Thanks. Yep, that sounds better. Come back, 30 seconds. Family health history. This is due for 2014. Only new requirement is that for first-degree relatives, minimum requirement, which is parents, siblings, and children, you can associate each of those, your father, your mother, both of them, siblings and your children with a SNOMED code. So if your mother had breast cancer, you could pull down a thing for your mother and then associate a SNOMED code with her, or heart disease with your dad. So pretty low threshold on that. Patient list creation. This is, they've combined two from 2011. This is just really a list generator based on record, EMAR. It's for the hospitals, being able to track medications that are ordered through every step and make sure that the right person's getting the right medication, right dose at the right time, to tracking it all the way through. Inpatient setting, just keeping track, same as 2011. Is there any advanced directives? Now this is a big one here. These two, transitions of care, receive, display, and incorporate, and transition. Reconciliation. This is just where we could prove from two data sources we could reconcile to a single list from two different sources, problems, medications, labs, and maybe medication allergies. No, medication allergies are problems. Don't have to incorporate labs. That's good. Here's the one that we're going to do as part of clinical decision support, incorporate lab tests and values results. So we have to show that we have the functionality to do this to generate clinical decision support. So again, it'll just be processing a sample lab file, bring in some structured data, generating that rule, triggering that rule. Inpatient, this is when you're sending out lab results to ambulatory providers. Not doing that. Data portability. Due for 2014, it's a good idea. When somebody's EHR vendor goes out of business or they want to switch to another vendor, that the old legacy system has the ability to generate a big stack of patient summaries, CCDAs. It'd be easier to get that data into the new system without having to manually enter it. Hopefully that'll work. Clinical quality measures, three things here. This was 2011. It was very subjective. Now for 2014, much more structured. They have some really good testing tools. Those clinical quality measures. That's a good thing. Come down to the security and privacy. And these just have to do with the ability to show that we have unique user IDs. We are permission-based. We can deactivate users. We can tell when audit log has been modified. We can generate audit reports. So when health information has been modified or copied or printed or deleted. We find out when it happened, who did it, who the patient was, action taken, amendments. Patient makes a request to amend the record. Keep track of that, but very, very simple. As soon as you're automatic logged off, just timed inactivity. So if the session ends, no protected health information is left on the screen. The session is actually ended. Emergency access, allowing somebody who's been pre-approved to break the glass during an emergency and access part of a electronic health record that they normally don't have permissions to. These are good things. End-user device encryption. If an end user, if you're using a laptop or a tablet or PC or a smartphone or anything else, and the session ends, and when the session ends, no unencrypted data, patient data is left on that system with temporary files or caches or cookies or something like that. Integrity, just showing that we have hashing algorithms in our system. So if we ever wanted to generate hash values off a file before and after transfer, we could do it. It hadn't changed in 2011. Optional carrying disclosures, that was there in 2011. That hasn't changed. This is a giant new one. View, download, and transmit to third party. This is a patient portal. It is complex. A lot of people do secure messaging with it. You have to really push a lot of information out to a portal for patients or their representatives, and you have to track when patients come there, because part of meaningful use is 5% of your unique patients during a certain period of time actually have come to the portal. So that's brand new. Patient engagement, that's a big deal. Clinical summary, this is generating a CCDA office and visit. Secure messaging, this is new for 2014. Trying to get into security a little bit here, and this is the ability to secure, send secure messages using a direct protocol from one authenticated email address to another authenticated email address. And this takes a while to test. And back in 2011, we saw people go through the complete certification if somebody's really prepared in 3.5 to 4 hours. Now it takes a minimum of 2 days because there's just so much testing for all these things and testing tools. Immunizations really hasn't changed until you document immunization and then generate a valid HL7 immunization file off that information. That hasn't changed. Public health syndromic surveillance. This is ends in 2011. Really hasn't changed 2014 significantly. This is if suddenly everybody starts coming down with anthrax poisoning or plague or influenza. We generate some HL7 files and send it to the CDC or the local health department or statewide agencies. So that's identical to 2011. That should be helpful somewhat down the road. Hospital only, being able to report reportable lab tests and values and results. And this is really hadn't changed in 2014. This is the requirement so that if you're getting a lot of venereal disease, let's see, and you want to report that, those kind of things to a health agency, they can kind of keep track of it. So it's important your reportable lab test. And the agencies got to tell you what they're going to be reporting on. Cancer care information, these two are totally optional. It's generating some information that can be sent to a cancer care registry. The only HRs that are doing that are those that are oncology specific. Really, it's optional. Automated numerator recording and automated measure recording. These two have to do with the when providers or hospitals attest for meaningful use. They got to have some numbers. They have to know how many unique patients they've seen and how many prescriptions they've written, that kind of stuff. And they post those numbers into the CMS web-based forms. And if they pass that, they get checked, and maybe they get audited, maybe they won't. But these two have to do with the ability of having a dashboard to generate these numerators and denominators. For clinical decision support, we don't have to worry about that. Safety enhanced design is due for 2014. They want to make sure that your application or some modules have you've had 4 or 5 or 6 or 20 users in a kind of controlled environment do some different functionality, have some drugs interact, put in some new problems, do an e-prescription, things like that, and then it's a structured way to get feedback from them to help improve your product. Now, for clinical decision support, it's not included in the modules, so you don't have to worry about that. But you do have to do quality management system. And this is not functionality. This is just when you apply the test, they're going to ask you to do provide a document that outlines what your development process is, what your development cycle is like, specifications, QA, what you do with bugs, stuff like that. It's not a 20-page report. It's 1 page or less. But that's just part of your self-attestation that you provide to them during the application process. Yeah, I think I set a record, did that in about 15 minutes. I knew I did it at a super high level. But, those are all the 2014 standards. Now, modules, one thing that's kind of interesting is if somebody got certified for 2011, like a complete EHR, and they come back for 2014, they only have to test against modules that are new or certified. So it's called a gap test. And so things like computerized provider order entry, which have not changed, they don't have to do that again. And they get credit for 2014. But clinical decision support has been changed so much during 2011 and 2014 that anybody who did it for 2011 has got to test that again for 2014. Big changes like that. So there you go. Any questions about any of that kind of stuff, or what you think? Maybe you can unmute now.
This is Tony. So
Yeah.
that noise is definitely coming from me, huh?
Okay. Yeah, I guess it was because it got quiet after a while.
Okay.
So yeah.
So anyway, this is good. It was just straightforward, and we didn't have anything particular
Yeah.
that we were doing.
A couple things I do want to mention, is that it's kind of good that you've got this plan to demonstrate your certification functionality by using that CCDA, because that CCDA is the the health information exchanges once they get up and running in the sky. The molecules that are going to build them are going to be those CCDAs. That's what's going to be up there. There may be some X-rays and some other things, but basically it's going to be those CCDAs. And so all these things, transfer of care documents, as well as, let's see, what else is in there? Transfer of care, these transfer of care documents, anything that has to do with moving patient data is really based on that CCDA.
Yeah. View, download, transmit, some of those.
Yeah, no doubt about it. And so the fact that that is the looks like the best path of functionality for you to do your certification theater is also the best path for the fact of integrating with that known standard. Because 2 or 3 years from now, there may be something set up where people want to start shooting at those CCDAs, because that is the standard, and it's wired down through stage 3. And so I'm kind of pleased that what looked like the best way to do things is going to be the most efficient way also for certification. So to be able to accept that CCDA and do something with it, generate clinical decision support, I think that's great. I like that that's worked out so far anyway.
Excellent.
Yep.
Yeah, looking forward to seeing what that file looks like in my little Oxygen XML spy program. I'm familiar with the normal CCD, so it'll be interesting to see. We've heard the CCDA talked about a lot, but not really seen it. So
yeah,
great.
And one thing I know Wayne's going to send you this, but here's a fascinating thing where there's some CCDA samples that have been generated by different certified EHRs, And I'm going to, I'm sorry. Let's see, where to go there. I'm going to copy this and put it in the GoToMeeting chat window.
And that's good, because that's one of the things I'll add for you. But yeah, that's good. We can look at it now for sure.
Yeah, and so put it in there. Yeah, and Wayne sent you a link too. But see, there's all script samples, Cerner samples, Greenway samples, samples from a bunch of different vendors on their CTDAs coming out of their certified system. So it's, yeah, there's a lot of availability of these out there to play with for sure. And that, Wayne, that, well, I keep forgetting this is great because you do not have to even generate one. But we will need to, you know, build some test ones. We're not having to generate test ones, but we can just take some established samples and monkey around with them to make sure that that we can do things. And let me see where the, let's see, the NIST CCDA. Let's see if it's next to the CDA validator. They may have some, no, that's the 2011 one. Do you know where that is, the validator? Because it may have samples there also.
Yeah, let's see. See if I got that in my file.
Yeah.
I got tons of things regarding CCDA.
Let's see. That's not the one we want. It is a NIST. Yeah. Well, anyway.
I'll give it to you. Yeah, I'll send it to you.
Yeah, exactly. Good. But yeah, it's great we don't have to generate it. And so I could really see that building some internal structure to you know, to push a button and process that CCDA and a lab file, and then to generate some alerts based off those. I see a pretty clear path forward. You know, so I don't think there's a big unknown out there. We should talk to, and we'll, if used to, we'll help you talk to InfoGuard, you know, to, you know, kind of outline the plan and get their buy-in on it. But I think we've got a good plan. So yeah, be glad to.
So,
but yeah, go ahead.
We've confirmed that in its current state, the software would not meet the certification.
Right.
However, there is a plan that we have that we kind of have talked about here that we believe would be able to get us there. The specific items, and so in terms of therapeutic guidance, would want to incorporate that from Dr. Gashford, because obviously that might he might have some preference on that one, but I think we have a pretty good feel on that one, and then it's just the theater making sure it's kind of locked solid with the CCDA standard, with being able to retrieve that, as well as just being able to incorporate lab test results with that HL7V2 lab message telling us something.
That's right. That's right. And so I will, by early next week, I'll kind of get a summary report to you, kind of outline this stuff, but also suggesting for your consideration next steps, which is the things you just discussed, but also discussion with your testing body to make sure that this plan meets their expectations.
Okay, so we'll need to spec out our plan just in a format that that we could have then just validated with InfoGuard, and then based on that plan, we will be able to satisfy our customers' AMSA with being able to provide an estimate for how much it would take for us to put these
exactly. Yeah. I don't know who's doing the testing stuff at InfoGuard now, so but before a lot of work gets done, I want to make sure that they say, yeah, the way you're talking about having a CCDA in a lab and processing that, that sounds good to us. The other testing bodies we work with all the time, this would be no problem. But I always like to look way ahead and see where there might be problems. And I want to make sure, that's clear that they don't have any problem with the process strategy we've come up with. So I'd like to, and I'd be very glad to be involved. It's a 20-minute call. It's not a big deal. Outline the strategy, say this is how we'd like to demonstrate this. You see any problems with that? And, I just don't like things hanging. I want to make sure they buy into the process.
I agree. Let me take a look. Next week's a really busy week for us.
Yes.
But maybe, I've been loosely monitoring the emails regarding the contract, but I assume that's all well in hand.
Yeah, sure, no problem.
And so if I could, as long as there's nothing that would prevent us from having that call the following week.
No,
okay.
No, that's fine. That's fine.
Okay.
Yep.
Awesome.
And so, again, I don't know how much you're in contact, let's see. Actually, let's see. I'm kind of the next week, which is Monday the 16th. I'm kind of traveling some that week, but like the 19th or 20th would work for me, which is Thursday or Friday that week. And I'm totally open both those days. Wayne, I don't know about your schedule.
Yeah, that would work.
Yeah, and again, and so I don't know whoever your contact person is. How close are you to InfoGuard? You've had a call or two with them.
We have a pretty good. I'm muting myself here. We have a very good, informal relationship with them. So
okay.
I'm trying. Well, I mean, pretty good at it.
Yeah. Well, what I'm saying is, you can just email them and say, you're going to go ahead and get this thing certified, and you're thinking about, I don't know, sometimes it's just easier to have a 20-minute call than to do the, a bunch of descriptive emails take you hours to write.
I agree.
Yeah.
We've spoken with Milton's our contract person there, and he's still there.
Yeah.
And Scott is the actual tester person. So so we can kind of move it forward to the point where trying to even see what a contract would look like, in terms of engaging them too, because we'll need that for our estimate anyways.
Right. And so if there is a problem with InfoGuard whatsoever, I know that at least ICSA would have no problem with this strategy because I've done a lot of these with them. But, you already work with InfoGuard, so that's fine. So we'll make sure that they buy off on it. So anyway, the 19th and 20th look good. If you want to do it sooner, I know no, that's probably as soon as I could do it, but.
Okay, 19th is looking amazingly better than the 20th right now.
Okay.
So let me just I'm going to make a meeting called placeholder.
Okay.
And
send that out.
Let's see.
Yeah.
All right, so placeholder. So Jim Tate. And I'm sorry, it's Wayne.
Singer.
Yeah.
Oh, you didn't pop up in. Putting your email address in the chat window.
Sure, I'll do that.
If you right click on his name.
Yeah, that too.
Yeah.
Right click name. The copy. Yes, it will. All right, nice, Jim. I got you. Placeholder for call with InfoGuard.
Yeah.
What time on Thursday?
Let's see, where are y'all? Oh, you're on the East Coast.
InfoGuard's on like Pacific.
Yeah.
Or they're in Arizona, so they're.
Yeah. So I don't know whatever you want to do it.
Well, afternoon then would work, right? Afternoon.
Yeah, afternoon is preferable.
Yeah.
Okay, that's good. That's good.
All right, I'm checking the calendars on this side. All right. We're going to go ahead and just send that out.
Right.
I'll call it tentative. Not only is it a placeholder, it is a tentative placeholder.
Even better.
Excellent. Well, thank you very much.
Okay.
The encore presentation, the recording of this will be up on that wiki page
Okay, great.
a little bit later on that you can use that. It'll be interesting to see what the recording's like. Because of the connection, I was interrupted a couple times, and it'll be interesting to see
Sure.
that sound. Obviously, since you're hearing, I suspect that probably made it into the file as well.
Sure.
So,
But next week, if any questions come up, or I think Wayne's going to send you some links and some references, resources. If any questions come up, just shoot us emails.
okay. Excellent.
About anything. Yep. Okay, gentlemen. Talk to you soon.
Great.
All
Great
right.
to meet you, and have a wonderful weekend.
You
Thank
too.
you. You too. Bye-bye.
All right, thanks.
Looks good.
Bye.
Bye.